we've talked about the invalidating environments. What else comes into play when one is trying to diagnose a borderline personality disorder? Because I know it's a little tricky. It's not as simple as that.
Yeah, it's pretty tricky. I think there's a lot of misconception about diagnosis of BPD, and I think one of the biggest misconceptions is in order to get the diagnosis, you have to have some sort of self harm or suicidal ideation in your history. And you do not.
Hmm.
I will say the majority of people with BPD do, but it is not a required criteria. There are 9 symptoms that are listed in our diagnostic manual, and you have to have 5. But whatever iteration of those symptoms that you have, whether you have 5 or 6 or 7 or 8, and which 5 you have or whatever, they just have to create a pattern of emotional instability and unstable relationships. That's really the big picture.
Hmm.
So we hear sometimes about quiet BPD, and what you might see people with quiet BPD is they have all the same symptoms, but the pattern of emotional stability is not visible from the outside in. These are folks who learned to deal with their emotions by pretending they don't exist. So they're still feeling them on the inside, but nobody on the outside would know. They're not acting on them. And it's also really tricky to diagnose because there are so many symptoms that overlap with these other diagnoses. So I can't tell you how, I think there is research. I don't remember the exact statistic, but it's an incredibly large number of folks with borderline are initially diagnosed with bipolar because they come into the therapist's office or the psychiatrist's office and they describe how they are outside of the office. And it sounds like these really big changes. And if you don't ask like what the duration of those episodes is,
Hmm.
it could be bipolar, right? Oh, I get really impulsive and I think really highly of myself. And I decide I'm going to start a new business and change my hair and do all of this. And the psychiatrist goes, oh, okay, like manic episode. And anecdotally, I find that this misdiagnosis often happens if the person doesn't fit the stereotypical picture of BPD.
Hmm.
So if they don't self harm, or if they can hold down a job, or whatever it might be, if they're not ticking those stereotype boxes, the psychiatrist won't even think borderline. They'll say, here's this person sitting in front of me who looks totally normal describing this chaos. That chaos must have happened during a manic episode. They must be bipolar.
That makes sense. I remember in graduate school, they had a chart. I don't know how much things have changed, but back then it was assumed that 72% of people diagnosed with bipolar 2 were actually would have better met the criteria for borderline personality disorder. And that's a big distinction when we're talking about the difference between a chemical imbalance,
Mhm.
which is more or less kind of is more of a permanent kind of thing that can be managed versus a, a psychologically developed condition that can be reprogrammed,
Mhm.
right? In essence, I don't know if there's a savvier way to say that, but that's kind of how I think about it, and the difference. And even we could go into a whole rabbit hole of just bipolar disorder in itself, right? And, bipolar 1 versus bipolar
Mhm.
2 versus bipolar rapid cycling versus so on and so forth,
Yep.
right? Um, seasonal versus etc. Yeah, so it gets a little sticky in the diagnostic area. That's why I was curious, because I know those who, that term gets thrown around, oh, this person's borderline or that person's borderline. Really, oftentimes, what's being referred to are borderline traits as they're thought of, right? Like the splitting or the protest behavior, the fear of abandonment, rejection, the impulsivity, the self harm, the cutting, the headbanging, all of that, promiscuity, the substance use, that are easily generalized into a bucket, and I
Mhm.
think we need to be careful as consumers of mental health, as practitioners of mental health, and the general population, which is why I'm so glad you're on today, so we can raise a little awareness around this, is that we need to be very careful about how we generalize because those labels already have enough stigma attached. right? Which is a big part of the problem to begin with. Yeah.
And there's so many symptoms that are transdiagnostic.
Mm-hmm.
So by that, what I mean is that you might find the same symptom. You might find impulsivity in bipolar. You might find impulsivity in ADHD. You might find impulsivity in borderline. You might find impulsivity in PTSD. You might find impulsivity in a lot of different things, in autism,
Mm-hmm.
right? There's a bajillion different things where you might find impulsivity. So using impulsivity as, oh, that's how I know this person has this diagnosis is tricky.
Mm-hmm.
And I mean, the way that we diagnose is imperfect, and we have to work within the system that we have for now. But I think what happens is the general public, people who don't spend their lives deep diving into the research, which why should
Right.
they? The general public, the way that we talk, the way that we communicate about mental health to the public is we say, here's this diagnosis and here's an infographic about it. And, if you're most of these, then you might have this. And what people come to think is that a diagnosis is an on off switch.
Mm-hmm.
Either I have anxiety or I don't. I have depression or I don't. I have PTSD or I don't. And that one day I'll be able to just flip that switch off and I won't have depression or I won't have anxiety or I won't have PTSD. And that is really oversimplified. And I don't think that's a helpful way to think of oneself, as having 5 things where the switches are flipped on and trying to flip these switches off. I think it's a lot more helpful to think of dimmer switches.
I like that.
And instead of there's a BPD dimmer switch and you have it all the way up or not, no, there's an impulsivity dimmer switch and that's up or down. There's a quickness to anger and that's up and down. There's a likelihood to act on the anger and that's up and down. There's a quickness to return to baseline and that's up and down. There's a difficulty reading faces and that's up and down. There's a propensity to interpret faces as negative, that's up and down.
Mm-hmm.
And you have 10,000 dimmer switches and 20 of them would be under the impulsivity umbrella. And if most of those are turned up, we would say you're impulsive. And then we've got another umbrella of fear of abandonment, and that's got 20 different switches. And if most of them are turned up, we would say you've got fear of abandonment. And then that might be autism, and it might be BPD, and it might be ADHD.
Yeah. It might be labeled with attachment disorder.
It might be attachment disorder. How old is the person? How long has it been going? All of these factors. And that's really, when we're diagnosing people, that's what we as professionals should be thinking of, as a wall of 10,000 dimmer switches.
Mm-hmm.
But it's really hard to communicate that to the public instead of just, okay, you have BPD or you don't.
Right. Everybody wants a simple answer. The problem with simple answers is that's what leads to stigma. Right.
Yeah.
Like that I have versus I experience.
Mm-hmm.
I have experienced anxiety. I have experienced trauma. Right. It's not a fixed thing. It's like you said, sometimes when the intensity of those experiences are cranked up, then it flags maybe a label. But I like to think of diagnoses oftentimes as a compass. The reason we have diagnoses to begin with, same thing in the medical field, so that they have something they can target, right? And it could be wrong. It could change, right? Doesn't mean that it's salient or fixed. Right?
Yeah. And that's, in DBT and in many other therapies, we start with the life-threatening behavior first, whatever we're going to call that. You want to call it depression and you're suicidal? Fine. You want to call it BPD and you're suicidal? Fine. We're going to target the suicidal thoughts. And then once those have been managed effectively, then we can target, okay, well, what's the next most serious thing going on? I just heard a really, really wonderful presenter. His name is Alan Frizzetti. He is part of the National Education Alliance for Borderline Personality Disorder, which, conflict of interest disclosure, I am on the board. But he just gave this really wonderful presentation. He was talking about insomnia. And he was saying, we tell people, well, you have insomnia because you're depressed. But But they could be depressed because they have insomnia,
Oh yeah.
and they could be impulsive because they're not sleeping. And they could have insomnia because they're mismanaging their diet or something like that, right?
Mm-hmm. Mm-hmm.
There's so many different causes that interplay. And to simply write somebody off and say, okay, well, you're depressed and that's why you can't sleep. And so here's a sleeping med and here's a depression med, we're not actually fixing the problem for that
Mm-hmm.
person. And if we call it depression, we haven't helped that person. But
Right.
if we say, man, not sleeping sure is one heck of a problem that is having a domino effect on the rest of your quality of life.
Mm-hmm.
Let's figure out how to get you some sleep. Let's do a sleep study. Let's get some labs drawn. Take a look at that. And then once you're sleeping, then we'll take a look at your mental health because half of this might go away.
Right. As opposed to getting tunnel vision on
Yeah.
one particular idea and one symptom and just running with that, right? It's about the holistic bird's eye view and making sure we don't lose sight of the other moving parts, right? The other levers we can pull, right? And like you said,
Mhm.
there's definitely a hierarchy, right?
Yeah.
When we're talking about treatment with anything, right? So risk, right? And then basic needs and then quality of life, kind of in that order.
Yeah. I mean, I even in my own life, um, I take vitamins, but I'm a child, so I buy each individual vitamin in gummy form, so that way I get to have like 10 gummies
Nice.
every day.
I
That's
love it.
how I motivate myself to take my
Well, I love gummy
vitamins.
bears as a kid, right? And I can't be the only one.
No multivitamin for Catherine. Um, but I was having a lot of trouble sleeping, and I was talking to my psychiatrist at the time, and she actually did a really comprehensive, holistic workup. And she asked me about my vitamins. I say I take my vitamins every day. She said, "Okay, what do you take? And when do you take them?" I said, "Well, I take all of them before bed. They're like dessert." And she goes, "You take your B vitamin before bed?" And I said, "Yeah, with all my other vitamins, because I'm great at taking vitamins."
Right.
And she goes, "Okay, well, that's why you can't sleep. Take that in the morning and then see what happens in 2 weeks." And that was it. That was the fix.
Mm,
I didn't need CBT for insomnia. I didn't need better sleep hygiene. I mean, I'm certain I would benefit from it. But really, the fix in that moment was to take my B vitamin in the morning.
right.
And had I gone to somebody with tunnel vision, we never would have caught that. I would have ended up on a sleep med. I would have maybe groggy all day, you know.
Makes sense, especially B3.
Yeah.
Niacin. Niacin is a well, I'm not a registered dietitian or anything, um, but it can be used to increase your energy, so that makes sense.
Mhm.
Yeah, excellent.